All right, let's go ahead and start review questions for general surgery. So you have a 42-year-old male presenting in your clinic for routine annual physical examination. He's in good health and has no complaints at this time. His vitals are within normal limits. On physical examination, you palpate a firm 1.2 centimeter nodule just inferior to his Adam's apple on the left side. He denies any pain as well as any symptoms consistent with hyper or hypothyroidism. TSH is ordered and is normal. Which of the following is the best next step in the management of this patient? A. Excisional biopsy. B. Fine needle aspiration. C. CT of the neck. D. Thyroxine. Or E. Follow-up in 6 months. All right, and the answer here is B. Fine needle aspiration. So what we have here, an assessment, is a 42-year-old male with a thyroid nodule. Presumably a thyroid nodule. It's in that area. And the first thing that you want to do, just first thing off the top of your head, when a patient has a thyroid nodule, is to ask them if they have any symptoms consistent with hyper or hypothyroidism. So you want to ask them, has there been any change in your appetite? Have you gained or lost any weight? Have you had any difficulty sleeping? Etc., etc., etc. So another thing that you're going to want to do in addition to that is get a TSH. And a TSH is important when you have a thyroid nodule. Thyroid function tests, which include TSH, these are important because if a patient has abnormal thyroid function tests, and by abnormal I mean a low TSH and a high T3, T4, so hyperthyroidism, that's actually reassuring because when we see a thyroid nodule, the first thing, most concerning thing that we're thinking of is thyroid cancer. And if a patient has a nodule that's functioning, then that nodule is not cancerous. When you have a patient with thyroid function tests that come back abnormal, showing hyperthyroidism, you can do two things. You can either go ahead and just diagnose the patient with a toxic adenoma or toxic multinodular goiter, but it usually helps to get a radioactive iodine uptake scan. You can do this either way. You can do this if the patient has normal function of the thyroid or if they have abnormal thyroid function tests. But you definitely have to get the radioactive iodine uptake scan if they have the abnormal thyroid function test, because you've got to look for where the hot nodule is and whether or not there are more than one nodules, because a lot of times when a patient has a functioning nodule, there's actually more than just that one nodule, but you can't feel the rest of them. So it's helpful to get the radioactive iodine uptake scan just so you can see if there are any more than just that one that you felt. And so toxic adenoma would be if you were to just have one thyroid nodule, but toxic multinodular goiter would be if you were to have multiple. So they're really the same kind of disease. It's just the question is whether you have one or multiple. And these can be taken out, or you can treat them suppressively. Typically, they're treated surgically, though. So now, on the other hand, like in this patient where we had normal thyroid function tests, you can do a radioactive iodine uptake scan. I don't expect that you would be asked to choose between fine needle aspiration or radioactive iodine uptake scan. Some clinicians would do a radioactive iodine uptake scan. However, it is perfectly okay to go for the fine needle aspiration right after you find out that you have a normal thyroid function test. So when you have a normal thyroid function test, what you can gather from that is that this is a nodule that is not functioning. It's just a nodule of thyroid tissue, but it's not thyroid tissue that's secreting any thyroid hormone or doing anything. So what you want to do from there is a fine needle aspiration. And the reason is because if it is the so-called cold nodule, the non-functioning nodule, it can still be cancer. So you do the fine needle aspiration. The nodule may be cystic, in which case you would get usually like a clearish fluid out of it, or it may be solid. Either way, what you're doing is you're sending off the contents of that fine needle aspiration to cytology, and the pathologist will tell you what cells were seen, if any. And if it's cystic, there's usually no cells present. If it's solid, there are cells present. The question is just what kind. So there's various ways that a solid nodule can come back. Of course, the most concerning is cancer, in which case we would have to treat as indicated. There are multiple different kinds of thyroid cancers. Each of them confer upon the patient a different prognosis and a different treatment. Of course, we're going to be excising the cancer if it is cancer, and the only exception to that is would be one different type of cancer, which we'll talk about in the next slide. So there's carcinoma, and then there's follicular abnormality, quote unquote. We don't really need to know what that looks like, but you should know that if it comes back as a quote unquote follicular abnormality, you need to excise the mass. If it's Hürthle cells, you need to excise it, but not necessarily because it might be cancer. You need to excise it because it could be cancer, but you can't possibly know just based on the cytology alone. So a Hürthle tumor may be benign, but it may be malignant. There's no way, though, you can tell just based on fine needle aspiration. So what you wind up having to do is an excisional biopsy. So you're going to excise it no matter what. And then you can do the biopsy, and you can find out this was a benign Hürthle cell lesion or this was a malignant Hürthle cell lesion. Either way, the treatment is excision. So it doesn't really matter whether it's benign or malignant. If it's Hürthle cells, you're taking it off. Adenomatous hyperplasia is a little bit different. So we treat adenomatous hyperplasia by administering antithyroid drugs and then observing the nodule. If it shrinks, then you can just continue to observe it. If there are no changes, you will repeat the fine needle aspiration, and if it grows, you're going to excise it. And then, of course, if you have an indeterminate fine needle aspiration, you're going to repeat it to try to get better results. So question 2 is referring to the same patient. You got a TSH, order was normal, fine needle aspiration was done, indicates cells consistent with medullary carcinoma. So which of the following, then, is the best treatment for this patient? He's got medullary carcinoma. A, radioiodine ablation. B, resection of the mass with histologically clear margins. C, near total thyroidectomy. D, near total thyroidectomy with post-operative iodine ablation. Or E, total thyroidectomy. So we're doing surgery. Question is, what procedure? And the answer here is E, a total thyroidectomy. So this is based on the type of cancer that the patient has. So remember that there are many types of thyroid cancer, 4 that you really need to be aware of. The type of thyroid cancer that the patient has is going to dictate what we do to treat the patient. So in this case, the patient had a medullary thyroid carcinoma, but there are many different thyroid carcinomas, 4 that you need to be aware of. The first of which is the most common, papillary thyroid carcinoma, which makes up about 60 to 70% of all thyroid carcinomas. A papillary thyroid carcinoma just needs to be treated with a near total thyroidectomy, and you don't necessarily need to do radiotherapy. But for the USMLE, if it's a papillary thyroid carcinoma, all you need to know is that it's a near total thyroidectomy for treatment. Papillary thyroid carcinoma is associated with a history of radiation exposure to the head or to the neck. If it's a follicular thyroid carcinoma, and this occurs more often in older patients, you need to do a near total thyroidectomy, but you also have to follow that up with a post-operative radioiodine ablation. And the reason you're doing that is because follicular thyroid cancer spreads through the blood. And after you remove the nodule, the thyroid cancer, follicular thyroid cancer, you're not quite done because there may be still cancer cells in the blood. And the last thing we'd want to do is subject a patient to surgery, send them off on their own, and then have them present 6 months later with metastases all over. So what we do, because this is a cancer that spreads in the blood, and there can still be cancer cells in the blood, possibly after we do the surgery, is to give radioiodine ablation, and that kills off any remaining cancer cells in the blood, so we know that for sure we've treated this. Now, this patient had a medullary thyroid carcinoma, and a medullary thyroid cancer kind of stands out for one reason, and it's because it tends to follow genetics. And a patient may just sporadically develop a medullary thyroid cancer, and usually it's because of their genetics, but it's sporadic, or they can develop it as part of a familial syndrome, which you could have predicted because the patient has a family history of most often multiple endocrine neoplasia type 2. So the multiple endocrine neoplasias, 2A and 2B, if the patient has that, you're actually going to remove the thyroid before they even develop a medullary thyroid carcinoma. You're going to remove it as soon as you make the diagnosis of MEN 2A or 2B. However, in this patient who's got the medullary thyroid carcinoma, we're going to remove the entire thyroid, and the reason is he's got a predilection for medullary thyroid carcinoma based on his genes. So even if we just remove the tumor or most of the thyroid, it doesn't matter because whatever remaining thyroid is there is eventually going to develop cancer. So it's useless to just remove the tumor. You've got to remove the whole thyroid because the whole thyroid is in effect diseased and is going to develop cancer at some point. So for medullary thyroid carcinoma, we treat it via total thyroidectomy. You've got to know that for the USMLE. So this was a patient with medullary thyroid cancer. We don't do a near total thyroidectomy. We take out the entire thyroid. Anaplastic thyroid carcinoma also stands out. This is a very painful thyroid tumor, and it's also terminal. There's no way we can cure this. So there's no point in taking out the thyroid because you're not really going to confer upon the patient any increased survivability or any increased, they're not going to have, you're not going to add years to their life. All you're going to do is subject the patient to unnecessary surgery. So with anaplastic thyroid carcinoma, the treatment is just palliative, which may or may not include surgery. But removing their thyroid will do absolutely nothing for treating their cancer. Okay, question 3 is a 25-year-old woman presenting to your clinic concerned about a mass she felt over her right breast. She doesn't know how long it's been there. She denies any symptoms of pain in the breast or nipple. She has any nipple discharge. Her medical history is only significant for type 1 diabetes mellitus. Her medications include sertraline and an insulin regimen including glargine and Lispro, which are your short and long-acting insulins. Long and short-acting insulins, respectively. Her family history is significant for breast cancer in her aunt at age 43. Physical exam is significant for a 1.8 centimeter mobile rubbery mass in the upper outer quadrant of the right breast. No axillary lymphadenopathy is present. Which of the following is the best next step in the management of this patient? A, breast ultrasound, B, mammography, C, fine needle aspiration of the mass, D, core needle biopsy of the mass, or E, lumpectomy. Okay, the answer here is A, breast ultrasound. So this is a classical presentation based on her symptoms, her age, and how the tumor appears on breast examination of a fibroadenoma. And a fibroadenoma is one of the most common breast masses that you're going to encounter in a young woman. Now, that having been said, when you have women coming in, young women coming in, and they feel a breast mass, they're going to be horrified. They're going to be really, really scared. In the United States, we have a culture that surrounds breast cancer, that we are very, very aware of it. There's all sorts of fundraisers that we do, and awareness drives to make sure that people know about breast cancer, and people sure do know about breast cancer in this country. So when a young woman feels a mass over her breast, of course, if you don't know that fibroadenoma is a clinical entity, and certainly most of us didn't know it was a clinical entity until we went to medical school, you're going to think it's breast cancer, and you're going to be horrified. And so One of the most important things to do immediately is when you feel the mobile rubbery mass, which is very typical of a fibroadenoma, is to reassure the patient that this is probably not cancer. It's more than likely not cancer. But we still need to work it up, because theoretically a mass can always be cancer, and you always need to make sure that you know what it is. So the first thing we're going to do is image it, because you need to image a mass before you're going to go in and take a biopsy. That's a rule of thumb. So the question then becomes whether we do an ultrasound or mammography. And for the most part, if the woman is under 35 years of age, we do an ultrasound. And if she's older than 35, we can do a mammography. Mammography is easier and also a little bit more accurate. But younger women have denser breasts. And if you look at a mammogram, you'll see that it looks like an X-ray. And a dense breast is very white appearing on the mammogram. And so what is also white appearing, though, is a mass. So when you're looking for something that's white over something that's white, it's very difficult to find it. So what you're going to do is an ultrasound. An ultrasound will help you find the mass much easier. So if a woman is under the age of 35, an ultrasound is a superior imaging technique to mammography. But if she's older than 35, mammography is just fine. So here is a fibroadenoma, and you'll note that what you have is very dense breast tissue, which is this hyperechoic area surrounding this lesion, which looks like kind of like a cyst. It's a hypoechoic mass, and it's kind of hard to tell here, but this is roughly 2 centimeters wide. This is your scale here. So you have a 2 centimeter lesion, and after you are you've found the mass and you've identified it on imaging, then you can go ahead and take a biopsy. And the biopsy is going to be important because, and by biopsy I mean either fine needle aspiration or core needle biopsy. The biopsy is going to be important because it nails in the diagnosis that this is a fibroadenoma as opposed to something else, which, again, theoretically could be cancer, but 25-year-old woman, probably not. Very, 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 very few people who have breast cancer are under 30 or even 40 years old. So this is a cancer that increases with age. And it's very unusual it would be very unusual for a woman who's 25 years old to have cancer. So if you were to choose a technique to get cells to make a cellular diagnosis, which would you choose? A rule of thumb for breast lesions is that if you're weighing more towards that this is a benign lesion, like for instance in this patient who it's almost certainly a fibroadenoma, then the imaging or the biopsy technique that you'd want to do is a fine needle aspiration. But let's say that this was a 45-year-old woman, and the likelihood of cancer would be much greater than in this woman. A core needle biopsy would be better. So if you're leaning towards benign, fine needle aspiration is better. If there's a real possibility that this is malignant, statistically, then a core needle biopsy is better. And fine needle aspiration has some superiorities in that there's fewer complications and it's less invasive, but a core needle biopsy is better at detecting cancer. Now, the lumpectomy is not the right answer, but ultimately this will be something that we will do in this patient if she indeed does have a fibroadenoma, because this is a very distressing mass, and women usually want it out. So we're more than happy to oblige. So it's an elective lumpectomy, and you should make sure that your patient is aware that this isn't cancer, it's not going to turn into cancer, it doesn't put you at increased risk of cancer, and taking it out is only just going to take the mass out. It's not going to make you any healthier. But if you want it out, you can have it out. Okay, so these are some of the benign lesions that I went over in the benign breast mass section. A couple other ones that I just want to point out, or one other one that I want to point out, is something that's very similar to what we had here, but it happens rather than in a woman in her 20s or 30s, it happens in a child, is the aptly named juvenile fibroadenoma. So let's say that this were a 15-year-old that had the same presentation. In this case, it's going to be a juvenile fibroadenoma, and it's very similar to a fibroadenoma, except for the fact that juvenile fibroadenomas tend to be on the bigger side compared to fibroadenomas. It's ultimately identical to fibroadenoma. The big difference, though, is that it's important to remove the fibroadenoma. It's not really so much, it's not as much an elective removal as much as we're really, really pushing removing a fibroadenoma if it's on a young girl. Because what's going to happen, even though this is usually this is a benign mass, what happens is if the girl has not finished developing yet, the breast is going to grow around it. And if you were to take it out much later, you would have a breast that has developed abnormally and it's deformed. And you don't want that. So we want to take this out because of aesthetic reasons, so that we don't have a breast that develops poorly. Okay. So these other ones, notably intraductal papilloma and fibrocystic change, very, very important to know. You'll run into them a lot. And so I really recommend going back, if you haven't already, and looking at these benign lesions. Okay, so question 4 is kind of a follow-up on this patient. So the ultrasound was performed. It reveals a 2 centimeter hypoechoic mass, followed by a diagnostic fine needle aspiration, which suggests fibroadenoma. Patient chooses elective resection, and the diagnosis is confirmed on biopsy. So she's all fixed, right? She doesn't have her mass anymore. She's elected her surgery. It's gone. Assuming no further breast events, at which age should this patient begin receiving annual mammography? Is it A33, B38, C40, D43, or E50? Okay, and the answer for this one is B38. So this has nothing to do with the fact that she had a fibroadenoma. What this has to do with is the fact that she has a relative who had breast cancer at a specific age. And when it comes to deciding when a woman needs to start getting annual mammography, the general rule is she starts getting it at age 40 and then every year after that. Now, if she has a family history of breast cancer, the question then becomes, what age did that relative have it? So if it were, the rule is we take 5 years, we subtract 5 years from whatever age the relative was at when they got their breast cancer, and that's the age that we start surveilling the patient. So for this patient, her aunt got breast cancer at 43, so we subtract 5 years off of that. That gives us 38. And so we're going to start surveilling her at 38 years of age. This is important to know this because this has to do with general health maintenance. If you're going into family practice, you've got to know this. Very, very, very important, because you want to make sure that your patients are getting their preventative health measures. So if this patient, though, had a family history and she said, well, yeah, my mom got breast cancer at 55 and my grandma got it when she was 73, well, we wouldn't need to do anything any earlier than normal, because remember, you're subtracting 5. So what really matters is if you have a family history of a relative getting breast cancer at age 44 or younger. The older you get, the more likely you are to get breast cancer. So if it's an older relative, it's not so much, we're not so much concerned that this is a really genetic thing. But you can have older relatives get breast cancer, and that can mean that you're at increased risk for breast cancer, but it doesn't change the surveillance. The surveillance is based on if anybody in your family got breast cancer at age 44 or younger. You just, like I said, you just take 5 years off of that age. Now, let's say that she had a cousin that got breast cancer at age 30. Well, then we're going to start monitoring her every year at age 25. But remember, if they're younger than 35, you're going to use an ultrasound. If they're older than 35, then you can do mammography. So question number 5 gives us a 62-year-old man presenting to your clinic complaining of progressive difficulty swallowing for the past 3 months. He says it feels like the food gets caught up in his throat as he points to his chest. He says it's to solids only, and he hasn't noticed any trouble with fluids. Patient is otherwise healthy. He denies symptoms of reflux or regurgitation and denies heartburn. He has a 60-pack year smoking history and used to drink a beer or 2 daily until age 50. Lung sounds are clear to auscultation. Heart rate and rhythm are regular. Abdomen is soft, non-tender, non-distended. Bowel sounds are normal. Rectal exam is negative for masses, but positive for stool guaiac. Which of the following is the best next step in the management of this patient? A. Upper endoscopy. B. Barium esophagram. C. Esophageal manometry. D. MRI. Or E. Endoscopic ultrasound. Right, so the answer to this one is B. Barium esophagram. So this is a patient with dysphagia, and when you have a patient with dysphagia, first question is, are there any of the quote-unquote alarm symptoms? So our alarm symptoms are anything that would statistically make you more likely to have cancer than have something benign going on, like a stricture. So our alarm symptoms are age more than 60 years, which is this patient. Anemia, which we don't know is this patient or not. He doesn't have any symptoms, but it doesn't mean that he might not have anemia. We would have to look at the CBC, but we don't know that for sure. Heme-positive stools, which would be this patient. Symptoms greater than 6 months, which isn't this patient. And then weight loss, unintended weight loss. So this patient, even if he were to just have one alarm symptom, so even if he wasn't positive for stool guaiac, we're still concerned about cancer. But the fact that he has 2 alarm symptoms makes us even more concerned about cancer. So if you were to have been asked what's the most likely diagnosis in this patient, the most likely diagnosis would probably be squamous cell carcinoma of the esophagus. Now, if he had not had the smoking history, not had any history of drinking, but had a history of reflux disease or current reflux disease, then your most likely diagnosis would probably be adenocarcinoma of the esophagus. Either way, whatever the most likely diagnosis is, if we're concerned about cancer, the very, very, very first thing we do is a barium esophagram. Now, you may have thought, well, why are we not doing an upper endoscopy? We need to get a biopsy on this patient to see if this is cancer or not. And yes, you're right, we do. But the last thing we want to do is to go in with an endoscope, which, I mean, you kind of have to push it in there a little bit, and then puncture diseased tissue because you don't know where it is. And you puncture it and you cause bleeding or perforation or something of that nature. That would be terrible. So what we do to get around that is we first get what endoscopists like to call a road map. And it's called a road map because it tells them where the lesion is exactly, how many centimeters down, so that they know when they're pushing the endoscope down, they know when they need to become much more ginger with the endoscope. So this reduces the risk of perforation. So we get the barium esophagram pretty much exactly for that reason, to reduce the risk of complications from the endoscopy. At that point then, yes, go ahead with the upper endoscopy, have your biopsy tool ready, and then you can make your diagnosis. So here is a barium esophagram, 2 of them, one on the left here, another one on the right, in different patients. So this would be what we would probably expect in this patient here on the left. This is a lesion in the middle third of the esophagus, which would be more consistent with the squamous cell carcinoma, which is consistent with a patient who has an extensive smoking history, or a history of alcoholism, or epidemiologically is black compared to white. Blacks have a higher risk compared to whites for squamous cell carcinoma of the esophagus. On the other hand, this on the right is very distal, close to the gastroesophageal junction. This is more than likely, you can't tell until you get a biopsy, but you could bet the farm that this is a adenocarcinoma of the esophagus. And this has a higher incidence in whites and in patients who have gastroesophageal reflux disease, especially if they have Barrett's esophagus or they have had poorly treated reflux disease. So these are your road maps. Once you get these, then go in with the endoscopy. And it's actually quite common for the endoscopist to have the picture of the barium roadmap right there, either on the white screen or on the computer, right there, so he or she can see it while they're doing the endoscopy. So the endoscopist remembers exactly where that lesion is. I've seen endoscopists do that. So that's how important this barium esophagram is. So question 6 gives us this 28-year-old male presenting to the ED complaining of a panic attack. He says he has been diagnosed with panic disorder by a psychiatrist whom he sees every month, but that he has never had a panic attack last this long, which he says is about 15 minutes. He's prescribed lorazepam 1 milligram for as-needed use, and he says he's already taken one and it didn't do anything. On physical exam, you see an anxious-appearing young man who is tremulous and diaphoretic. Lungs are clear to auscultation. He's tachycardic, but there's normal rhythm. Vitals show a blood pressure of 180 over 115, heart rate of 135, respiration is 24, temperature 98.6, and a saturation of 100%. Which of the following would most likely not be part of the initial workup on this patient? A, basic labs, B, thyroid function tests, C, plasma metanephrines, D, MIBG scan, E, EKG, F, urine toxicology, G, urine metanephrines. So this is a question kind of geared towards step 3 people, when you have to check off all the things that you need to do and not check off the things you don't need to do. So it always helps when you're deciding what you want to do to have already made your differential diagnosis. So then you know what labs you want to run, what labs you don't need to run. So the answer to this one is D, MIBG scan. So what's our differential diagnosis? We've got a guy that's coming in, he's got panic disorder, he's had this quote-unquote panic attack, which he's describing it as a panic attack that's lasted 15 minutes plus. That's not a panic attack. So panic disorder, yes, you get these panic attacks, but they come out of nowhere and they go away usually within a minute or two. Also, they are usually responsive to benzodiazepines. So he has lorazepam, he took it, it didn't work. So I'm not, to be honest, I don't remember exactly what the cutoff is for panic attacks, but panic attacks are rarely longer than a couple minutes. So this is almost certainly not a panic attack. So now, as we know that, we see him, and he's tremulous, he's diaphoretic, he's got a really high blood pressure, he's tachycardic. So what's going on here? What's our differential? So you can, the first thing that comes to mind is pheochromocytoma, based on the fact that he is relatively healthy, except for his panic disorder. He doesn't really have anything else. Another thing that it could be is a thyroid storm. Typically with thyroid storm, they have an established history of hyperthyroidism, but not always. So thyroid storm is a possibility and should be on your differential. Another thing it could be is an arrhythmia. So the arrhythmias we think of, the tachycardic arrhythmias, are PSVT. So paroxysmal supraventricular tachycardia. So that usually is in older people, but this, again, you have to cast a wide net. So that's another possibility. Another possibility, especially because he's a young male and because he's got a psychiatric history, and these are just epidemiologic risk factors, is that there may be some illicit drug use. I mean, not all patients will admit this to you, so you have to keep a high index of suspicion. So urine toxicology is useful to get, just, again, casting a wide net. So now that we look, basic labs definitely going to be useful. That's pretty much retrieved in any patient that's coming into the ED. Thyroid function tests will help us differentiate out thyroid storm. plasma metanephrines and urine metanephrines will help us to determine if it's a pheochromocytoma. The EKG helps us determine whether or not this is an arrhythmia, and then urine toxicology helps us to see if there's any drug use, and what we're looking for primarily here is cocaine and amphetamines. So the MIBG scan, you probably know that this does play a role in pheochromocytoma, but this is not going to be part of your initial workup. An MIBG scan is a nuclear medicine test, and it's a test that you do when you already know that the patient has pheochromocytoma. Right now, we don't really know yet, so we're trying to just do our workup to make a presumptive diagnosis. If you had already diagnosed the patient with pheochromocytoma, sure, an MIBG scan can be a really good test to determine where the tumor or tumors are, but right now we're still in our initial workup, and an MIBG scan is long and it's expensive, and there can be complications, and so this is not going to be part of our initial workup. All right, so same patient, plasma metanephrines return elevated. Which of the following is the best initial treatment for this patient? A, adenosine, B, metoprolol, C, candesartan, D, phenoxybenzamine, or E, CT of the abdomen? All right, so the answer to this question is D, phenoxybenzamine. So you should know that the best initial treatment for a patient, apart from any stabilization if you need to do that, but the best initial treatment for a patient with pheochromocytoma, which we have diagnosed this patient with based on his elevated plasma metanephrines, the best initial treatment is alpha blockers. Do not choose beta blockers. So the USMLE, I guarantee you, will ask you this question at some point in your test. Step 2 or step 3, and they're going to want you to know that you start with alpha blockers, not with beta blockers, and they want you to know that because if you gave this patient a beta blocker, you may kill him. So a metoprolol is a beta blocker, and that would worsen the patient's condition, so that is absolutely out. These other drugs, adenosine would be the appropriate drug to use if he had a supraventricular tachycardia. It can abort that. And then candesartan is an angiotensin receptor blocker. That's not preferred because the problem here is not angiotensin. The problem here is catecholamines, primarily epinephrine. So that's not going to be so much useful either. If you want to use an alpha blocker as your initial treatment. Okay, so I found this on a hospital's website, and the reason I put this on here is because globally, I'm not exactly sure what the practices are for treating pheochromocytoma. I imagine it's somewhat similar to what we have here, but I'm not sure. So I saw this on a hospital's website, and it was interesting because what you have are very different treatment plans. So this is the one that you're going. This one, option 1 here, with the alpha blocker followed by the beta blocker. Is the one that the USMLE will want you to know. So this is the one you want to remember, not this one on the right. So you're going to start with the alpha blocker, and then after a few days, you can administer a beta blocker. That's fine. As far as Demsur and the calcium channel blocker, Demsur is just the trade name for metiracine. You don't need to do these, Demsur or calcium channel blocker. Again, you may see this done in the hospital, but it's not necessary. So USMLE doesn't expect you to know that, even though it may be done in some practices. So if they are done, the idea behind Demsur is that what it is it blocks the production of catecholamines. So now you've got you're working on 3 ends. You've got your alpha blocker, your beta blocker, which reduce the effects of the catecholamines, and then the Demsur reduces the production of the catecholamines. So that's why it's used. Preoperatively, what you want to do is replace fluids and then administer phenoxybenzamine before the surgery. And then during the surgery, you're only going to use fluid replacement. And remember, before all of this, you need to see where the tumor is, because even though most of the time the pheochromocytomas are in the adrenals, they can be in other places. So most notably in that area where the aorta bifurcates, the organ of Zuckerkandl. All right. Question 8. A 69-year-old woman in your care has been admitted for fainting episode suffered this morning. You notice on her chart that she had an initial hemoglobin of 7.9. She was transfused in the ED, stabilized with fluids, and the attending ED practitioner noted positive stool guaiac. She is already scheduled for colonoscopy, scheduled for tomorrow. You notice that her liver function tests were significant for a total bilirubin of 2.3 and an alkaline phosphatase of 600, both of which are elevated. You perform a right upper quadrant sonogram, as you should, and identify an enlarged, thin-walled gallbladder and dilated common bile and hepatic ducts. In addition to her already scheduled colonoscopy, which of the following procedures is now also indicated in this patient? A. A barium enema, B. Upper endoscopy, C. CT scan of the liver, D. Percutaneous transhepatic angiogram, or E. Endoscopic ultrasound of the pancreas. Right, so the answer here is B, upper endoscopy. Why? I made this question somewhat vague because I want you to be aware of this cancer. So what we have on assessment is a woman with a severe anemia, and you have labs that were abnormal in addition to the anemia. Now, a lot of times in practice, you're going to, you may run into abnormal labs that weren't already noted. And this is very common when a patient comes in through the ED, because the role of the emergency physician is to stabilize the patient and, if necessary, get them either admitted or get them to a physician who will admit them in the hospital. So a lot of times, and it shouldn't happen, but a lot of times it does happen, the ED physician overlooks some abnormal results because they're usually taking care of 5 or 6 or 7 patients that they need to get stabilized and discharged or admitted. So in this case, you noticed liver function tests that showed a T-bili of 2.3, which is severely elevated, and an alkaline phosphatase of 600, meaning when you have a total bilirubin that's elevated, and specifically an alkaline phosphatase that's elevated, something is going on in the biliary tract. And we don't know what that is. Now, clearly what the assumptive diagnosis here was that she has some kind of colon cancer, and that is common in older people who have anemia. So the colonoscopy would certainly be a great test to do. But we have a woman with abnormal liver function tests. And furthermore, what you should do anytime you have abnormal liver function tests, if you don't know what's going on, is a right upper quadrant sonogram. It's easy to perform. It's cheap. It can be done handheld by the physician. You should do the sonogram and look at the gallbladder and the biliary tract. And indeed, when you find the biliary tracts, you see this really, really problematic enlarged thin-walled gallbladder. And there is a name for an enlarged thin-walled gallbladder, particularly if it's painless, and it's called Courvoisier-Terrier sign. And this is cancer until proven otherwise. But a colon tumor wouldn't do that. So what else could be there? It's very unlikely she has both colon cancer and another cancer, especially in the small intestine, which would be where this would be. So where is this? What is this? A tumor that is in the biliary tract that can cause bleeding could be an ampullary cancer. Ampullary cancers would cause this blockage, would cause this elevated alkaline phosphatase and the total bilirubin, possibly even jaundice, and causes the bleeding too. And so this kind of would make sense in this patient. You've got bleeding, plus you've got the large gallbladder, which is consistent with cancer, and then you've got the total bilirubin and alk phos that's elevated. So that would all fit in with the ampullary cancer. Ampullary cancer is not common, but you have to be aware of it because of this very typical presentation. So yes, indeed, she is going to get the colonoscopy because colon cancer is way more common than ampullary cancer. But we need to check for ampullary cancer too, because with colon cancer, you're not going to have the enlarged thin wall gallbladder, and you're not going to have the disturbed liver tests. So what do we do to look for an ampullary cancer? It's as simple as getting an upper endoscopy. You can usually find it just by putting the scope down there, finding the ampulla, and you'll see the cancer that's right there. You can do a biopsy at that point and make your diagnosis. But in clinical practice, if you were to have this patient, you certainly are not going to cancel her colonoscopy. She's still going to get a colonoscopy, but you'll include an upper endoscopy because an upper endoscopy will help you diagnose ampullary cancer. So be aware of how ampullary cancer looks. Question 9 gives us a 23-year-old man who's brought to the ED by his girlfriend. He's doubled over in abdominal pain. She says that they had been drinking the night before, and about 4 hours ago he vomited twice and suddenly screamed in pain, which has been unrelenting since then. Physical exam reveals an ill-appearing male withering in extreme pain. Blood pressure is 150 over 100, heart rate 120, respiration 16, temperature 99.7. Chest x-ray reveals subdiaphragmatic air. Which of the following is the most likely diagnosis? A. Mallory-Weiss tear, B. Gastric perforation, C. Aspiration pneumonia secondary to emesis, D. Dissecting thoracic aortic aneurysm, or E. Boerhaave syndrome. This one is relatively straightforward compared to some of the other ones that I've been giving you. The answer here is Boerhaave syndrome. So your typical presentation history of Boerhaave syndrome is a patient who went out drinking and then started vomiting the next morning or maybe a few hours later, and it was a violent vomiting, maybe some retching involved, and all of a sudden, pain. That is Boerhaave syndrome, until proven otherwise. Now, on the other hand, Mallory-Weiss tear can be similar, where you get this college student who went out and had a night on the town drinking, then the next morning started vomiting. But with the Mallory-Weiss tear, it's a superficial tear, not a transmural tear. And with the Mallory-Weiss tear, what you get is vomiting up blood, hematemesis. And that's not in this patient as far as we know. And Mallory-Weiss tears, while they can be painful, because anytime you're retching, it's painful, it's not the same kind of pain that you get in Boerhaave syndrome. Not the kind of pain where you have unrelenting pain and you're doubled over and you're writhing in extreme pain. That's Boerhaave syndrome. Now these other three, gastric perforation, that's likely not the case. I mean, theoretically it could, but it's likely not the case because gastric perforation, you tend to have a history of peptic ulcer disease. As far as we know, that's not in this patient. Aspiration pneumonia secondary to emesis. This emesis would probably not cause the aspiration pneumonia just because it was relatively recent, and also because you see the subdiaphragmatic air, and that wouldn't be explained by just aspiration pneumonia. Dissecting thoracic aortic aneurysm. This is older patients. 23-year-old, you are not thinking thoracic aortic aneurysm. Remember, on the USMLE, the question is not which of the following is the only possible diagnosis. The question is which of the following is the most likely diagnosis. So while you have a differential, you're not being asked to choose the only one. You're being asked to choose what's on the top of your differential. What is the first thing that you're thinking of that you're going to run tests for because it's the most likely thing. So in this patient, it's a very classic, clear presentation of Boerhaave syndrome. And if it wasn't obvious enough based on the presentation, the chest x-ray shows subdiaphragmatic air, and that's consistent with a rupture of the distal esophagus. So Boerhaave syndrome can be severe. These patients need immediate surgery. And so this is why you need to, if this is the diagnosis, you need to know right away. Okay, question 10. You arrive for rounds in the morning, and your nurse tells you that a 71-year-old man in your care has developed abdominal distension, colicky abdominal pain, and is extremely nauseous. You visit his room. He is presently relatively comfortable, but says he feels bloated and constipated. He has not passed gas or had a bowel movement since yesterday afternoon. Physical exam reveals visible abdominal distension, mild generalized tenderness, no rebound or guarding, no masses. Rectal exam is negative for masses, and the rectal vault is empty of stool. Stat abdominal x-ray is ordered and reveals distended large bowel with loss of Hausdorff markings and a large ovular shadow from the left lower quadrant to the right upper quadrant. He is vitally stable, and there are no signs of peritonitis or shock. Which of the following is the best next step in management? Is it A, NG suction fluids and NPO, B, rigid sigmoidoscopy, C, mesenteric angiography, D, emergent exploratory laparotomy, or E, emergent resection and Hartmann's procedure? On the next one, I've got the x-ray. I hope this doesn't tell you the answer, so you might want to pause it and figure out what your answer is before I... Yes, okay, good. So here's your x-ray. Now, you may be expected on the USMLE to just know what this is without looking at the x-ray, just being told what the x-ray is described as. But if you're taking step 2 specifically, you'll probably be shown the x-ray. All right, so what is this? What's the next step in management? You need to know what it is before you know what the next step in management is. All right, so the answer here is B, rigid sigmoidoscopy. This is a patient with sigmoid volvulus. Why do we know it's sigmoid volvulus and not something else? Well, the x-ray really helps. But in addition, sigmoid volvulus tends to occur in older patients, patients that don't necessarily have a surgical history. But the other thing in our differential is that's really common is a small bowel obstruction. Now, if this were a small bowel obstruction as opposed to a sigmoid volvulus, then the treatment would be NG suction fluids and NPO, letter A here. But we know that this is not, just based on the abdominal x-ray, we know that this is not a small bowel obstruction, because a small bowel obstruction, your abdominal x-ray will show multiple distended loops of small bowel and air fluid levels. So that's not this patient. That having been said, now that we know it's sigmoid volvulus, why do we do rigid sigmoidoscopy? Sigmoidoscopy, even though it's not so much that we're looking for anything, the scope part, it's that we're sticking something up there, for lack of a better word. And usually when you stick a tube up the sigmoid, what winds up happening is that this untwists itself, and that cures the disease. That gets rid of the volvulus. So you've basically gotten rid of the problem behind all of this. So this is going to be what you go towards first. Now, there's one exception to that. If the patient happened to have fever, elevated white count, peritonitis, then we're really concerned about dead bowel. And in that case, you don't want to stick a sigmoidoscope up there. So in that case, you would be moving to surgery. And so that's where we would do the emergent exploratory laparotomy, and probably followed by a resection in Hartmann's procedure. Why are we not doing mesenteric angiography? Mesenteric angiography would be done if we were concerned about mesenteric ischemia, like a clot busting off and going down into the mesenteric vasculature. That's not this patient. This patient is comfortable, relatively comfortable right now. If you have mesenteric ischemia, you're never comfortable. Remember, patients with mesenteric ischemia, the sort of the buzzwords are that they have pain that's out of proportion to the findings. And so these patients are writhing in pain. They've got peritonitis. Not like this guy who's going to be talking to you rather calmly, describe himself as relatively comfortable, just a little bloating and constipation. That would never be mesenteric ischemia, or mesenteric ischemia. That would not be in this case. So this is sigmoid volvulus, and you can just make the diagnosis on the X-ray. This is clear as day, sigmoid volvulus. Why? Think of the shape of the sigmoid. This is kind of looks like a sigmoid, and it is a sigmoid. So what you've got here is just distension of the sigmoid, and it's so big that it's going all the way up through the liver. I mean, this is a massive sigmoid volvulus. They don't always look this big, but this is what's called the coffee bean sign. So remember how a coffee bean looks? I gave you a picture of what it looks like when we talked about sigmoid volvulus. You have that kind of, it's like a ovular shadow, but then you got this kind of line down the middle. And it can also be called a bird of prey sign. So whatever fits your fancy, what you want to call it. But this is, you should know this picture and have this image in the back of your head. They usually don't look a whole lot different than this. They might be a little smaller, but they usually don't look a whole lot different than this. And this is a sigmoid volvulus. Note that you don't have any haustral markings in this sigmoid. You've lost that completely because it's so distended. Okay, so another thing I want to just add is, so when you have colonic volvulus, most of the time it's sigmoid. Sigmoid's far more common than cecal. The first question you're asking yourself, which you should have asked yourself in this patient, is, does the patient have peritonitis? He didn't in this case. He was comfortable. There were no signs of peritonitis like guarding a rebound. And so since there's no peritonitis, then the very next step is going to be endoscopic decompression. Putting up your sigmoid, your colonoscope, your tube. I mean, there's various tubes that you can put up. I mean, you can put up a sigmoidoscope, you can put up a colonoscope. It's really just the preference of the, you won't be asked to choose between the two. It's really just the preference of the surgeon. But what you're doing is endoscopic decompression. You're sort of untwisting it. It doesn't really take that much work. You're just sticking it right up. Something to be aware of if you ever have to do this, think of what's going on. You've got this bowel here, the sigmoid, that's blocking everything up. What do you think is proximal to all of this? A bunch of gas and a bunch of stool. So when you are doing your decompression, make sure that you have your face covered and that you've got, you're aware of what's going to happen. It's going to be a release of gas and fecal matter. But that sounds terrible, and it is kind of if you're the physician, because that's never pleasant to see. But it's also kind of good because seeing that tells you that this was a successful decompression. So after that point, you'll do a bowel prep to stabilize the patient, and then do what's called semi-elective surgery. That's really a terrible word. It's kind of contradicts itself. I mean, it's either elective or it's not. But we highly recommend that the patient have the bowel out. And so we'll look for any kind of diseased bowel, but most of the time there's not if they didn't have peritonitis signs. Now, in the event that your endoscopic decompression was unsuccessful, wheels off for emergency. They're going to be getting surgery right away. You're going to be looking around to see if there's any diseased colon. If there is, you take it out. If there's not, you still take it out. But it's not dead colon. You're going to take it out because it's diseased. But if you don't have any necrosis there, we're not as much worried about huge complications. And so we're not so much doing the Hartmann's procedure. We're just taking the colon out. We're just taking the sigmoid out. So Hartmann's procedure is primarily done because what you have is inflamed colon, and you can't sew up areas that were around inflamed colon to each other. So this is a little bit more complicated on the surgical end of things. What you should be aware of, though, for the USMLE at the very least, is that if you've got sigmoid volvulus, if they don't have peritonitis, it's an endoscopic decompression. If they do have peritonitis, it's emergent surgery. Okay? If you have any questions, let me know. Otherwise, I will see you in the next section.